Hello, Oaknoll friends. My name's Lynette Marshall, and I have the privilege of serving as President and CEO of the University of Iowa Center for Advancement, and it's so good to be with you this evening. Each year, as you know, we really enjoy bringing the University of Iowa to you just across town so we can update you on campus happenings. And this year, despite COVID-19 restrictions, we continue that tradition thanks to the wonders of technology. I'm so sorry that we can't be there to enjoy a reception in advance and to have conversation with you, but we're happy to be able to bring you some really important updates from the University of Iowa. Throughout this pandemic, University of Iowa Healthcare has been on the front line of care for Iowans, and we've been leading the world in research toward effective treatments and, happily, vaccines. I'm delighted that we have two representatives from University of Iowa Healthcare here with us. We have Suresh Gunasekaran, Chief Executive Officer of the University of Iowa Hospitals and Clinics and Associate Vice President for U of I Healthcare, and Dr. Patricia Winokur, Executive Dean of the Carver College of Medicine and a professor of internal medicine with a specialty in infectious diseases at the University of Iowa Hospitals and Clinics. You'll hear from both of them shortly, and I know they have much to report. I can tell you it has been a privilege to support them in our work at the University of Iowa Center for Advancement, especially these past 8 months, as we have witnessed our healthcare heroes, and heroes they are, as they have done everything they can to support citizens during this pandemic. Last March, we launched an emergency fund and raised, with your help, nearly $120,000 for healthcare workers' most pressing needs. We've also been sharing stories during the pandemic, both online and in our paper version of the Iowa Magazine, about our other leading researchers, including Dr. Stanley Perlman, a professor of microbiology and immunology who has studied coronaviruses for 38 years, and until recently was one of the few people in the world doing so. We're also proud of genetics expert Val Sheffield, who developed a COVID test and converted part of his lab to help fight the pandemic. And then we also featured Mike Brownlee, our chief pharmacy officer, who is a key player in the hospital incident command system, ensuring our hospital staff had the appropriate personal protective equipment during the national shortage that we experienced last spring. Later on in our program, you're going to hear from Dr. Winokur about Iowa's role in the COVID-19 vaccine trials. And of course, the Center for Advancement has continued to connect with alumni and friends around the world with virtual programs like this one. In fact, since April, we have been pleased to be able to offer more than 125 virtual events, from chats from Old Cap with notable alumni to Professor Jay Holstein's Golden Anniversary Lecture, as well as a discussion I was delighted to have with Professor Emerita Marilyn Robinson, featuring her new book, Jack. And if you're a Robinson fan, Jack is a tremendous addition to the Gilead series. We've also continued with our popular senior college programming and even been able to put that online. So if you are interested, you can learn more about that on our website at foriowa.org. While this virtual programming has been a good way to connect with all of you, I really do look forward to today then we can gather together in at Oaknoll and see each other in person. So until then, I'm happy to present you with today's program virtually. We're going to start by welcoming Suresh Gunasekaran. Suresh is the Chief Executive Officer of UIHC, and he leads an enterprise-wide commitment to comprehensive primary and specialty care for patients and their families, focusing on clinical excellence, collaboration, and innovation, as well as quality and safety, and of course, outstanding service. In his role as Associate Vice President, Suresh works closely with U of I healthcare leaders to advance the organization's three-part mission of biomedical research, medical education and training, and patient care. Suresh, we're grateful for you taking time out of your day today to be with us.
Thanks, Lynette. It's really good to be with all of you today. We here at the University of Iowa Hospitals and Clinics are living in some pretty interesting times. We say it's hard to tell if it's the best of times or the worst of times. The worst of times, I think you're pretty aware of. This pandemic has been long, it's been hard, and it's been very challenging to our staff. But we're still here, and in so many ways over the past several months, we've seen the best of times at UI Healthcare, where world-class faculty have been able to make sure that we're on the cutting edge of treatment and therapy for coronavirus, where we've had nursing and respiratory therapists and other staff that have done their best not only to take care of patients that are in the hospitals, but also standing up our own clinics that are focused on treating COVID out in the community. We've pioneered using telemedicine to be able to connect with our patients and help them, even when they're in their own homes. We've stood up an unbelievable testing service for coronavirus, so that most everyone in Johnson County who wants to come to our facility for testing can get same-day turnaround, and so that they can quickly manage their own situation. So as much as we want to think about the worst of times here at UI Healthcare, it really in many ways has been the best of times. And what has really gotten us through it is not only the support of each and every colleague that we have here at UI Healthcare, but the tremendous support that we've received from the community. We've really been humbled by all of the support that we've received from the residents of Johnson County, but even the whole state. We've been really blessed to not only receive monetary support, but also the well wishes of all of our fellow citizens. And it's within that light that I would like to again thank Lynette and the Center for Advancement and all of you for your continued support of UI hospitals and clinics. At this time, it really makes a big difference to our staff and to our faculty to be a part of this community, but also to make sure that we're setting a good example. And that's really the phase that we're in right now. We feel really confident that regardless of what comes our way, we will be prepared to safely take care of all patients at University of Iowa hospitals and clinics. We will remain open. We do have the capacity. We do have the ability to take care of everyone. However, in this moment, what we do is not nearly as important as what the community as a whole does. And we are encouraging all aspects of the community to really think through the safety standards that have really kept us safe throughout this pandemic. And we're getting tired of this pandemic. I am personally very tired of it. It's gone on for a long time. There's been a significant amount of work, and it hasn't been easy. All of the sacrifices that we've had to make in terms of reducing the amount of times that we're able to go out to eat or get together with friends or travel or see loved ones, it's been really difficult. But there is a light at the end of the tunnel, and Dr. Pat Winokur is going to talk about that in the form of the vaccine. But there's still one period left before the vaccine where we really need to stick together and follow these safety guidelines and get through the holidays. And so during the season, in addition to taking care of our patients and in addition to taking care of our community, we continue to ask the whole community to stand with us, to follow the safety standards and help keep everyone safe. Because the best solution to the coronavirus pandemic is actually to prevent people from getting coronavirus in the first place. And we know we can do that through wearing masks, by social distancing, by avoiding gatherings, by practicing good hand hygiene. All of these are critical components in keeping each and every one of us safe. And so as I introduce Dr. Pat Winokur, I want to thank you again for all of your support and continuing to be a part of the UI Healthcare family. Dr. Winokur is really one of our champions and one of our leaders. She's a senior dean in the Carver College of Medicine, but she's also been on the front lines of working on the Pfizer vaccine trial. And I'd like to turn it over to Dr. Winokur at this time.
So thank you, Suresh. For those of you that don't know, I am very familiar with Oaknoll, and I do miss the fact that we haven't had a chance to kind of run into each other in the hallways, say hi, and touch base. I am still getting lots of updates. And for those of you that don't know, my mom is in Oaknoll, and so hi, Mom. This has been a tough time, as Suresh said. I think we all have done a great job, and I am so amazed at how well Oaknoll has done at protecting everybody. So my hat is off to all of you at Oaknoll for all that you've done. So as Suresh said, I've had the chance to work on the Pfizer vaccine trial, and it is finally starting to give us some hope that we are going to have a way out of this pandemic. And so I want to share today some of the information about the vaccine trial and just give you a sense of how we have been approaching this vaccine trial, not only at the University of Iowa, but around the country, and let you understand what is coming, because I think you will be some of the individuals that will have access to this vaccine much earlier than others. So I'm going to go ahead and share my screen so you can see some of the slides. And what I want to talk about today is the vaccines that we have been working on up front here for COVID-19 are novel, they're different, but we have really approached the development of this vaccine in a very careful way. And I'm going to show you why I think that's true. For those of you that don't know how a clinical trial is kind of staged as we go from test tube into release into the human population, we start with a lot of information learned in the test tube, trying to figure out what part of a virus is the best at stimulating an immune response. Once we understand the test tube side of things, we start working in animals to understand first, is the vaccine safe? And we often are using mice, rabbits, or monkeys. But we're also using those animals as a way to understand efficacy, because in animals, we can, in a very staged way, introduce them to the infection and see if they're protected. The second phase of vaccine development is really what we call phase 1, where we are introducing this vaccine into small numbers of people. We are following them very carefully for safety. We're looking at laboratory evaluations, electrocardiograms, all sorts of symptoms. We're starting to understand which of the vaccine candidates are best and starting to look at different doses. But we refine that in phase 2 when we go into about 100 to 300 people. And at that time, we're starting to understand, still safety is the biggest thing that we're following, but also what is the best vaccine candidate and what is the best dose. Once we pick that best of best, we pull it into a phase 3 study where we're typically studying 1,000 to 3,000 people. We're looking for any adverse events they may have. We're looking at blood samples to look for antibody titers, and we're looking at acquisition of disease. And I want you to pay attention to that number, 1,000 to 3,000, because that's going to come back. Once we've done this phase 1, 2, and 3 analysis, we have enough data typically to submit to the FDA for them to evaluate and confirm that this vaccine is safe and effective, and they will make a decision of whether to approve it or not. But that's not where we stop, because once we have FDA approval and it is released out into the general public, we continue to follow for rare events that maybe we didn't catch in those earlier stages. So safety continues to be followed even after FDA approval. You've probably in the news been hearing about this term emergency use authorization. Well, what is it? We know that the FDA has been given the rights to approve what we call medical countermeasures when the country is experiencing a public health emergency. That emergency might be because of bioterrorism, or it might be something like a pandemic. In practical terms, what it allows is an authorization to occur a little bit faster, a little bit earlier, using the best available evidence, and you're carefully balancing the risks versus the benefits. Typically, in this situation, the risks are pretty high. And so you have a little bit of a balance that favors speed. We do, again, even after emergency use authorization, go on to do a lot of safety and efficacy surveillance to make sure that we continue to have a product that is safe and should be deployed in the public. If you look at the difference between that and full FDA approval, now you're in a situation where there is a little bit less of an urgent risk. It's really the common infections that we see every day. Then that changes your risk-benefit analysis, and you're really trying to make sure that you're evaluating something with all the data available, the longest term follow-up, and you're making full approval. So you all have heard the term Operation Warp Speed. I can't decide whether that was actually a good term or a bad term, because I think it has made people worried that perhaps we have overemphasized speed. But I'm trying to tell you a lot of the background so you can make that decision for yourself. I can certainly discuss this at the end of where I think we've gone. But if you look at some of these different infections where we've tried to develop vaccines, I think Ebola is a great one. That's the bottom. You can see that we learned about this pathogen in the mid-1970s. Last year, 2019, we had a vaccine that was approved. So that took 35 years to develop a vaccine. Now look up towards the top. You can see that we started understanding that we had a problem with COVID-19 around March in the United States of this year, maybe a little earlier in other countries. And we've started to do a lot of science to understand it. But what has happened that has really escalated the speed is a lot of work that was done on two very related viruses, SARS and MERS. SARS was identified in the early 2000s, and individuals like Stan Perlman that Lynette talked about have been studying these viruses for decades. And SARS and MERS, they were able to actually learn an awful lot about the science of the virus and even start to develop vaccines that have helped us speed the transition to understanding how to protect people from COVID-19. So I told you just now that SARS and MERS are viruses that are almost identical to the virus causing COVID-19. They're all coronaviruses, and they all actually have the same target for antibody response in a human. That little spike protein, the red one that's sticking out on the outside of the virus, is the main protein that our body develops an immune response to that can go on and protect us from future infections. So this is where the payoff has come of all the science that was done for decades that has allowed us really to generate that warp speed that we're seeing with developing a vaccine for the COVID-19 pandemic. They even got vaccines developed for SARS and MERS that were tested in animals. They never ended up going into humans, but the fact that they had all that data on such a similar set of viruses has allowed the FDA to approve human studies much more quickly than we normally would. This is a tracker that you can see in the New York Times. This was from about a week and a half ago. Almost 60 different vaccines now are in human testing. That is unprecedented. There are 6 here that are very high in the phase 3 timeline of creating vaccines that could be approved. That is, again, unbelievably fast, but a lot of that is thanks to what's happened in previous research. When you look at a vaccine, we are always trying to balance safety with efficacy. And think about it, a vaccine is given to healthy people. We have to be more careful with a vaccine than we would perhaps with a cancer drug. We can't make people sicker than they already are. So that's always the premise when we're developing a vaccine. The 2 leading candidates that we have right now in the United States are 2 vaccines from 2 companies, Moderna and Pfizer. They are both very novel, new vaccine platforms. They use messenger RNA. Again, one of the things that has allowed us to create these vaccines so quickly is for the past 10 years, we have been developing platforms for vaccines that are much more malleable, that you can insert different proteins very quickly using molecular biology and get them into animal testing and eventually human testing faster. A lot of that work was done because we're developing cancer vaccines. It's a new strategy that we have for developing control measures or therapeutic measures for cancer, and those need to be fast. The messenger RNA is different in the sense, normally when we've done vaccines in the past, we know the protein that we need to target, we need to inject into a human to get them to develop an antibody. And we go ahead and make that protein in a test tube and eventually turn that into a vaccine. Well, the mRNA vaccine technology is actually taking advantage of your body and allowing your body to create that protein. And that's one of the advantages. So once this vaccine is injected, it's taken up into the muscle cells. And then the muscle cell actually takes that RNA and creates a protein. But not only does it create a protein, it creates a protein that almost absolutely mimics the proteins that are made when your body gets infected with COVID-19. And that is one of the ways that this vaccine has an advantage over some of the old traditional ways of making vaccines, because it expresses a protein that is almost identical to what would happen in a natural infection. And your body then creates an immune response to that protein. And you make antibodies and other immune cells that protect you. There are plenty of other things that have been done to really escalate the time efficiency for developing this vaccine. A lot of them are clerical, I would say, creating master protocols that allow us to move seamlessly from phase 1 to phase 2 to phase 3. One of the things that has helped is we have overlapped some of the efficacy studies in monkeys, not the safety. We've done the safety, but the efficacy was done at the same time we started the phase 1 trials in humans. And by the way, they do look effective in the monkeys. And then there are lots of other clerical things that have really helped us. We are enrolling very quickly and we are cleaning our data very quickly. The companies are analyzing the data very quickly, and the FDA, there is no getting in line for the data to be reviewed. They've got that data out to the experts immediately. So in October of 2020, the FDA did issue guidance to the companies of exactly what they were going to have to show FDA to meet the criteria for emergency use authorization. So they declared this up front. They told us that your vaccine is going to have to be 50% effective at reducing COVID-19 infections. They told us that they're going to be watching safety very carefully. They're going to be looking for new events, like perhaps an immune-mediated disease that might come from a vaccine. They're going to be watching for severe cases of COVID-19. You are going to have to show them safety data for 2 months after the second dose of vaccine in at least half the subjects. And you're going to have enough cases of severe coronavirus in the placebo groups to show that the vaccine isn't actually enhancing disease in those that get vaccine. So they very carefully set the exact parameters that they're going to be looking for as the data comes into them. So where are we today? The Pfizer vaccine is the one that you've been hearing the most about early. They completed their phase 1 and 2 studies in July. They started enrollment of 44,000 people. So remember I told you that a typical phase 3 study is between 1,000 and 3,000 people. We're over tenfold above that. So we're getting a lot of safety data. Half the subjects get vaccine, half get placebo. In this case, it's salt water. This trial started with those that were 18 and older, and it went from 18 to 85. They added 16 and 17-year-olds, and then they recently added 12 to 15-year-olds, so they got a little bit of data for kids. And the reason that we are so excited to have been part of the Pfizer trial is not only are we getting some upfront experience with the vaccine, and we certainly have some of the best subjects in the country, we did learn that the early analysis shows that the vaccine is about 90% effective in preventing coronavirus in our subjects. That is better than any of us hoped. We were thinking maybe 70%. 90% is remarkable. Moderna is another messenger RNA vaccine. They've completed their phase 1 and 2 trials, pretty similar time frame for the Pfizer phase 1s and 2s. They completed enrollment of 30,000 subjects, exact same design. 50% of the people got vaccine, 50% got salt water or placebo. They studied people that were ages 18 and older. They have just reported that they've reached their first time point for analysis of efficacy data, but they have not yet released the data or the percent protection. So we're all waiting with bated breath for that. Now, once you have the efficacy time points that you think statistically might be able to show that the vaccine is better than placebo, we are still acquiring the safety data. And that is probably for the Pfizer scheduled to go to FDA in about just right before Thanksgiving is when they will deliver this to Pfizer or to FDA for review. Moderna is a little bit behind, but still hot on the heels. So let's look at what's happening with the Pfizer data. So we do have some of the phase 1 and 2 studies published. And this was really an exciting time to start to see how well the vaccines were working, at least in the test tube, and understanding how well they're tolerated. So in this study, this is an evaluation of how well people tolerated the vaccine. We call that reactogenicity. And for all of you who've gotten flu vaccines or Shingrix or your hepatitis vaccines, you know that some days you get a low-grade fever from the vaccine, fatigue, chills, muscle aches, a little bit of that flu-like feeling. We can tell from this data, if you look at those between the ages of 18 and 64, first dose of vaccine, 40% of people showed fatigue, few people had fever, few people had chills. Okay, second dose of vaccine, you start to see that the reactions are a little bit more pronounced, a little bit more fatigue, a little bit more chills, a little bit more fever. So that second dose is often more symptomatic than the first, and we're seeing that. The good news is when your age is 65 to 85, you tolerate these vaccines a little bit better. So you don't have quite as many cases of fatigue. So that's great. But this is encouraging because these are side effects that we expect, and they're not overwhelming. The next thing we look at is the blood titers of antibodies. So all of our patients throughout are followed very carefully for blood sampling, as well as safety events. And you can see here, this is the 18 to 64-year-old group in this bar here. They had a pretty decent titer of antibodies here. Looks good. The bar's kind of big. Okay, we always like that. But the most important thing is now look far over on the right in the black. These are samples of blood from people who recovered from COVID-19. This is what's called human convalescent serum. And you can see here, this bar is higher than this bar. So what that is telling you is the vaccine is actually generating more antibodies than natural infection. And it's usually about 3 to 4 times more. So this is a really good outcome in the blood. In the 65 to 85-year-old group, the height of that bar is a little bit less than with the young people, but still a little bit better than human convalescent serum. So this is a good guesstimate that we're doing what we expect with the vaccine. But the most important data was that data that said that 90% of people who got active vaccines seemed to be protected from getting active disease. That is the proof in the pudding that we're looking for. So now we have a promise that we may have a vaccine, but we aren't going to have enough early on. This is going to be a scarce resource for a while. Pfizer has said that for their vaccine, they think they may have somewhere between 20 and 40 million doses by the end of the year. So now you have to figure out how you're going to prioritize delivery of a scarce resource. And as you can understand, that's a really controversial topic. It's a difficult topic. It's an ethical topic. A lot of different groups have been weighing in on what they think are the best strategies for delivering these limited doses. Probably the first thing that you're going to see is healthcare workers are prioritized to receive vaccine. And the reason is we have to keep the hospitals and the clinics open. This is critical. We are at a time frame where our hospitals and clinics are very stretched for personnel, and we can't afford to lose people to illness. We need them there on the front lines. If you look, there are about 21 million people that are in that healthcare worker population. So that's going to be a fair amount of the early doses of vaccine, but the second group that will be prioritized probably are going to be those living in retirement communities. And that's because we have seen some devastating transmissions in long-term care facilities, really high incidence of very severe disease. And we need to protect the most vulnerable people in our communities. So that will be another group. And if you add on to that, probably after the long-term care facilities and retirement communities, we will be vaccinating people with high-risk conditions. In the United States, that's about 150 million people. So still a lot of vaccine doses that are needed. After that, the predictions are it will be other critical workers that are essential workers. You know, people working at Hy-Vee are pretty essential. People that are working in building maintenance are very essential. So that's going to be a prioritization to keep the infrastructure for running the country and the communities open. And finally, we'll be vaccinating young adults and others, and eventually we'll be offering vaccine to children. What we anticipate is that to get to this point where we're vaccinating younger, healthier people, it's probably going to be later March, April, May timeframe. So that's an important point. So earliest vaccine availability with what we have going now, with FDA getting the data probably around Thanksgiving, is December will be the earliest that we'll see vaccine. It will be in limited doses and will probably be prioritized to healthcare workers first, and then long-term care facilities and family communities. The exact kind of sequence of vaccinating other individuals is probably going to be recommended by the American Committee on Immunization Practices that works very closely with the CDC. And we, in the state of Iowa, will be coordinating all of our delivery of vaccine with the Iowa Department of Public Health. And they will be guiding the distribution and use strategies in the state. We still have a lot that we need to learn. We will be following people for long-term safety. Remember that emergency use authorization, which is probably what we will be seeing first, has the 2 months data after people have gotten the second dose of vaccine. We will be continuing, obviously, in the studies to follow people for up to 2 years. We are also, once it's delivered into use in the population, going to be doing very aggressive safety follow-up in individuals that receive the vaccine. We have a lot to understand about the durability of the antibody response. How long are you protected? We know flu, you need a vaccine every year. We know with many other vaccines, 1 dose seems to do it, or a series of doses for the rest of your life. I think most of us anticipate that this might be more similar to influenza, where you need doses every year. We'll be obviously following the safety of repeat dosing if we do need to redose people in a year. Inevitably, we'll have supply chain problems. One company, you might get your first dose with Pfizer and then they run out of production. Can we switch over to Moderna or one of the other vaccines that's soon to follow? We need to understand safety in children, pregnant women, other special populations. So there's a lot still to learn, and rest assured that we are continuing to follow people very carefully to understand some of these issues over time. There are plenty of other vaccines that are in late stages of development. You've probably heard about Janssen and AstraZeneca. They were put on hold because of some concerns about safety, but even in the United States, they have released those now and they are continuing to vaccinate. Novavax is probably starting in another few weeks, and that's a much more traditional vaccine, protein subunit with an adjuvant, very similar to how we make a flu vaccine. Others are coming. So there will be other options in the future. And so I'm going to stop there, but I do want to really emphasize one thing. I told you that it's going to be probably April to May before a lot of individuals can get vaccine. And that means that even for those that are lucky enough to get the vaccine, you have to be very careful. It's not going to be a perfect vaccine. We know already the early data says that 10% of people can still get coronavirus. But there's going to be a lot of spread still going on in the community. And so it's going to be very important to maintain that diligence with wearing a mask, hand hygiene, and social distancing. So there's absolutely light at the end of the tunnel, but don't let your guard down just yet. Hang in there and stay safe. Thank you all for listening.
Great, Pat. A great presentation, Pat. I really enjoyed all the detail. I do want to ask you a few questions, though. You indicated that some healthcare workers, and then the next phase of distribution would include folks that live in long-term care facilities. I guess the question is, if you're at the front of the line to get the vaccine, do you think that you should get it? I mean, being the first people going through the vaccine?
So I can tell you my personal opinion, I will be first in line. I think we have really done a good job of following safety. One of the reasons that FDA picked that 2-month time point is because that's the time when almost all serious events happen after a vaccine. And remember, typically we're studying 3,000 people. We have 22,000 people that have gotten the vaccine for Pfizer alone. We're going to have another 15,000 people that got the Moderna vaccine. That is a lot of safety data. And so I'm pretty confident that we are doing a very good job of evaluating safety.
Well, that's good enough for me. I don't know if I'll qualify for the list, but I'll take it as soon as I can. But I do want to switch a little bit of gears here, if you don't mind. I know you have deep ties to Iowa City and the university, but I think the question needs to be asked, what sparked your interest to work in the field of infectious diseases versus psychiatry or something else?
So honestly, part of it started with the science. And when I was in college, it was a time when we were starting to learn how to use molecular biology to study viruses. And so that was the cutting edge science at that time. It was exciting, and infections were the place that they were learning how to use that technology the most. But then as I went through medical school, one of the things I really loved about infectious diseases is you're understanding the whole body. And not only are you understanding the whole body, you're understanding the patient and all their risk factors. And that allows you to talk to people and understand, do they travel? Are they at risk of getting malaria because they like to travel to Africa? Do they have pets? Some diseases are associated with owning animals or hunting. And so you get to know your patients in a really different way. And that was a lot of fun. And I still enjoy that detective work of really understanding the individual and understanding how they might have come in contact with some of these infections.
That's wonderful. And we're really lucky to have you here. Homegrown Iowa City success story. And we'll see. We'll hope that you'll keep giving us updates throughout the year, because I think there'll be a few more turns by the time this all gets done.
There are lots of things to learn. We'll keep working.
Thank you, Suresh, and thank you, Dr. Winokur, for your remarkable presentation. I would reiterate that it is really with a great deal of pride that all of us have such confidence in the University of Iowa Hospitals and Clinics and the Carver College of Medicine. And what a wonderful opportunity to get the insight on this Pfizer vaccine in particular, and the really optimistic news about that. So thank you so very much to each of you for being with us today. And to all of our friends at Oaknoll, we miss you. We wish we could come and see you and have a meal together, but that will come soon enough. And we thank you for watching this presentation this evening. Best wishes to all of you for a happy and healthy new year. Bye-bye.